Good morning, everybody. I think we should start. It's 10:30. My name is Patou Musumari. I'm an assistant professor working with Professor Kihara. And today we're going to see some basics of infectious disease epidemiology. So we will particularly look at few or some theoretical backgrounds on how disease spreads, but also on how we can control infectious diseases. And some of the very important concepts will be explored. The reproductive number, you will learn about it, and herd immunity. And in the second part of the lecture, we're going to I will introduce you to the mathematical modeling of infectious diseases. You know, what are the different steps involved in building a model. But before we get to that, I thought it would be really interesting to say some words about the pandemic influenza of the 1918-1920. It is generally known as the Spanish flu. I don't know if you ever heard about it. It's a very important disease to mention here because it has caused a global mortality that is more than any other pandemic since the bubonic plague or the Black Death of the 14th century that you have probably seen in one of your previous lectures. 1918, I'm sure many of you will remember, it's almost around the end of the First World War, and in which the United States was involved. And it all started here in this camp. They call it Camp Funston in Fort Riley, in the east side of east coast of the U.S. What happened is that on April 4, 1918, a soldier by the name of Albert Kitchell, he was an army cook in the military camp. He got sick with early symptoms of flu. Actually, it was the first reported case of the Spanish flu in that year. What follows is that on April 11, his symptoms got much more severe. He had sore throat and cough, very high fever, and his body was aching all over. And then he was admitted in the hospital. So let's try to look at it in a timeline. On March 4, he developed the first symptoms of flu. On March 11, that was in the morning, he was hospitalized. And on the same day, at around noontime, around 107 new cases with very similar symptoms were registered in the same hospital. And on March 15, which is about 10 days from March 4, there was around 522 new cases, and some have developed very severe pneumonia and died of it. Because the army, the troops were sent to Europe, so the infection rapidly traveled from the America to Europe. In May 15, it started in France. May and June 1918, most of the European countries had reported cases of pandemic influenza. Also in May 1918, some African countries were already hit by this pandemic. July, August Asia was also hit through India and China. This is in one of the places in the hospital where patients with pandemic influenza were kept. You can see how crowded it is. And obviously the hospital was overloaded by the number of cases that came up every day. Those are some collection of pictures that I had for you. And this here, it's showing a medical personnel giving treatment to a patient who was diagnosed with influenza. This is in one of the barracks where soldiers stay. And you can see that their beds are separated by those sneeze screens. And this is one of the measures that was taken at that time to try to control the spread of the infection. And here it's a sign showing the number of cases and death at the Naval Craft Factory. They're also saying don't spit, because at that time it was believed that spitting was one of the ways that the influenza was transmitted. So that's why they were urging people not to spit. And this is in one of the hospitals in the battlefield in Europe. And this is where they were putting patients with influenza. And this picture here showing a nurse wearing a mask. It's kind of signifying that they knew that the influenza was obviously transmitted by air. And she's filling a picture from a fire hydrant. As I say, it was a very, very deadly pandemic. And it is estimated that around 20 or between 20 to 50 million people died from this pandemic. And it took the lives of around 43 soldiers compared to 43,000 soldiers compared to 54,000 who died in the battlefield due to fight. So it's killed almost as much as the war itself, showing how epidemic can be very, very disastrous. And this is Tahiti. It's a small island in the Pacific. It is said that 10% of the population died in only 25 days. This is unbelievable. And another small islands in the Pacific, it's Samoa. 20% of the population died in only 2 months. But from the Spanish flu in 1918, there has been a lot of others pandemic influenza. We had the 1957 H2N2, the Asian flu, the Hong Kong flu in 1966, and we had the Russian flu in 1977. And the most recent one was the 2009, I'm sure everybody remembers here, the 2009 swine flu. But the world has witnessed many other emerging and re-emerging infections that you are well aware of. We have HIV, Ebola, that happened in West Africa recently. SARS, which means severe acute respiratory syndrome, in 2003. Poliomyelitis, which continues to to prevail in some of parts of the world. The dengue fever, I remember there was an outbreak in Yoyogi Park a few years ago. And now people are talking about Zika virus in Brazil, meaning that we are still at risk of those infectious diseases, and other emerging and re-emerging will continue to prevail. Okay, they say a picture can say 1,000 words. Let's see some of the pictures. Those are medical workers on the plane that came from Mexico in China, Shanghai, and they were checking people for signs of fever as a way to control the epidemic of in 2009. Those are workers spraying pesticide to kill mosquitoes in Tokyo's Yoyogi Park because there was an outbreak of dengue fever. And this is also a way to control the epidemic by destroying the vector directly. These are groups of Red Cross workers in Sierra Leone, one of the Western African countries that was hit by the Ebola epidemic. And they went here to check the house of a woman who was suspected to die from Ebola. And they had to take some samples. You can see them and the neighbors watching over about what's going on. Other Red Cross members here with a body of a man who was suspected also of dying from Ebola. So they were carrying him somewhere for very safe burial because they had to avoid contact with the body, the deceased body contact with the community, because this is one of the way Ebola can spread. And some of the practices in the region was that people are so much in contact with the dead body because they have to mourn. By mourning, they were being contaminated. So we had to avoid contact with the deceased body. This is a checkpoint where people would be screened for fever, any signs before reaching to another place. That's also in Sierra Leone, August 2014. And this is a health worker of the government of Sierra Leone keeping records of the quarantine in their checkpoints. So as you can see, from the pandemic influenza to recent epidemics of Ebola or Zika virus, there is something very common, is that infectious disease can transmit from one person to the other. This is the most important characteristic of infectious diseases. And that's what makes it different with other diseases like diabetes, which cannot be transmitted from person to person. Now that you have an idea about all that, let's look at some theoretical backgrounds of infectious diseases, which will factually help you to understand how disease spread in a community and what kind of measures we have to take to stop a specific kind of disease. What is an infectious disease? It's a illness, a disease caused by the transmission of a specific infectious agent or its toxic product from an infected person or animal, because some of the infections disease come from animal. It's not necessarily a human being. And it's transmitted to a susceptible host. and the transmission can be either direct or indirect transmission. There are a lot of ways to classify infectious diseases. One of the ways to look at it in terms of the clinical aspect, we have diarrheal diseases, respiratory diseases. We have disease of the central nervous system, cardiovascular infection, and we also have systemic infections when it is the blood that is infected. There is a microbiological classification as well. Infection can be caused by bacteria, virus. We have fungus or parasites, or sometimes the prion. Another way to look at it, and this is really important also for mathematical modeling, is to look at how the transmission is done. So it can be looked at whether in terms of contact. The contact can be direct, person to person, or indirect contact. We have a vector, mosquito, for example, transmitting malaria or dengue fever. Food and waterborne diseases, there are a lot of them, typhoid fever, airborne disease, measles, influenza, you can name it, and perinatal, from mother to child during delivery, for example. And other people look at the reservoir. The reservoir is the natural home of their infectious agents. So the reservoir can be human, for example, HIV, syphilis, gonorrhea. We have animal, and in that case, we talk about zoonosis. Soil, tetanus is one of these bacteria that we find in the soil. And water. And infections, or the dynamic of infectiousness, involve the infectious host. This is the person who is infected and is capable of transmitting the infection to other people. And we have a susceptible host, the one who's not yet infected but able to be infected if any contact with the pathogen is made. So the characteristics of each of the elements here will determine whether or not we have an infection or a transmission, and also how rapidly a transmission can be. So it will depend on the pathogen, what kind of pathogen it is, what kind of microbiologic processes is involved, the type of contact, is it direct, indirect contact? Those are very important elements to consider when it comes about looking at transmission of the diseases. Typically, for any infectious disease, we have a period where we are susceptible. We are not yet infected, so this is the susceptibility period. Once we get infected, there is a period that is called incubation period. This is the period where the bacteria or the pathogen, whatever it is, developing in the body. The characteristics here is that there is no symptoms. You look well, apparently. Then we have the start of symptoms, which is the symptomatic period, this period here. Any recovery or death, depending on the outcome. But when we look at transmission, the picture is just slightly different. In terms of transmission, we still have the susceptibility period. But then from the time of infection, we have one period that we call the latent period. The characteristic in this period is that the person is infected, but he is not able to transmit the infection to other people. And then you have the infectious period. Here, the person becomes able to transmit the infection. And that's why I've put an arrow here to show that there is ability to transmit the infection. And then the late stage is immune, death, or whatever outcome. It is also very important to note that the infectious period here, when we look at it in terms of the dynamic of infectious disease, the infectious period can start after the symptoms, or it can start before the symptoms here. This also means that the latent period can be longer than the incubation period, or the latent period can be shorter than the incubation period. And this has a very important implication when it comes to prevention of diseases. For example, in the case of SARS, the severe acute respiratory syndrome, generally, people become infectious after the onset of symptoms. This means that if we isolate people or we implement a quarantine, it is more likely to be very effective because you become infectious after you have the symptoms. However, when it comes to influenza, for example, generally, people become infectious before the onset of symptoms. So by the time you diagnose influenza, a sizable proportion of people have been already transmitted with the disease. So the duration of the latent period, or when the infectious period starts relative to the symptoms of the onset of symptoms, is a very, very important element showing that can direct which kind of intervention is better for which kind of disease. Another important element to look at is the generation time and the serial interval. Both generation time and serial interval tell us about the time scale of disease transmission. What is it? I will explain in detail now. Transmission is between two persons, from one infected host to one susceptible host. When the transmission is done, we can estimate the time it takes from this person to transmit the infection to the susceptible host. And one of the ways is to look at the generation time, which is the time of infection from the first person to the time of infection for the second person. They call it generation time. And it's natural to understand that if the generation time is very short, it means that the disease will transmit very rapidly in a population because the interval time is shorter. But most of the time, we know that we have a disease only when we have symptoms. So it's really difficult to accurately estimate the time of infection because generally we don't know. So what we do is that we look at what we call the serial interval as a way to estimate the generation time. The serial interval is the lag time between the start of symptoms from the first infected person to the start of symptoms from the second infected person. And the same principle applies here. A shorter serial interval means that the disease will spread rapidly. A longer serial interval means that the disease is spreading slowly. Here we have two scenarios, one of SARS and one of influenza. You can see that the serial interval of SARS is 8 days, while the serial interval of influenza is only 3 days. This means that influenza transmits more rapidly than SARS. And it's much easier to control SARS when we implement quarantine or isolation of cases than it is for influenza. Actually, one of the reasons it was possible to eradicate smallpox, it's because smallpox also have a very long generation time, which is about 2 weeks. And because of that, it was possible to eradicate smallpox. But very short generation time means that we need to identify the cases very, very rapidly before they start transmitting the infection to other people. So the question is how to measure the spread or the transmissibility of infectious diseases, and what influences the spread or the transmissibility of infectious diseases. We have seen two factors already. We have seen the generation time, mostly estimated by the serial interval. We have also seen the latent period in relationship with the incubation. Those are very important elements that influence their transmission, the dynamic of the transmission of infectious disease. But how do we really measure the transmissibility of infectious diseases? I'm sure you are very familiar with epidemiology, and most of the time when we want to measure the frequency of diseases, we use the prevalence, for example, which is the proportion of people in a population who have a specific disease at a single point, for example. For example, here on June 28th, 3,000 children residents in a city were diagnosed with malnutrition, and the total population is 18,000. So if we want to measure the prevalence of malnutrition on that day, it is just 3,000 divided by the population size, which is 18,000. So this is how we measure prevalence and as a way to estimate disease status. And another way to measure the frequency of disease, we use the incidence. We have the incidence proportion and the incidence rate, but the incidence proportion is the number of new cases of the disease divided by the number of persons followed during the period of time. The incidence rates, it's relatively the same, but we use the total time experienced for the subject followed. But both of them generally don't tell us nothing about the transmissibility of a disease. Another parameter is what we call the attack rate. The attack rate is one of the measures of incidence proportion, or it is just the risk of contracting a disease during an outbreak or an epidemic. For example, as more and more people get infected, the attack rate goes higher and higher. So it tells you how many people at the end of the epidemic were infected, for example, developed the disease. But it still doesn't really tell us how transmissible the infection is. So the prevalence is generally for measuring the disease status or the disease burden in a community, incidence, proportionate rates, and the attack rates are mostly measures of disease occurrence, how the disease occur within a population, but they don't tell us anything about transmissibility. One measure of transmissibility is the secondary attack rates. What is it? The secondary attack rate is the proportion of susceptible who become infected after contact with a primary case. So we need to have a primary case here, and then we need to see how many people who were in contact with that primary case became infected. So this one, they call it the secondary attack rate. This is just an example. In the 2009 pandemic influenza, they were comparing the attack rate between the pandemic influenza and the seasonal influenza. They found that both within the households, the secondary attack rates of both conditions were almost similar. However, the secondary attack rate is really not a perfect proxy for person-to-person transmission. Remember, I said the attack rate is the proportion of those who develop the disease after contact with the primary case. This is the primary case in a household, for example. And let's rule out the possibility that there is no infection coming from outside. Everything is in a closed environment. So 2 people, among the 3, 2 became infected. So the secondary attack rate is 2 divided the total size, 3 of them. So out of the 3, 2 became infected. So this is the secondary attack rate. But how did the transmission happen? We don't really know. There are many possibilities. For example, the primary case can infect both of them at the same time. Or another possibility, it can infect the one here, and the one up will infect the one down. And one other possibility is that it can come from the one down to the one up. So we don't really know exactly how person-to-person transmission happen when we just look at the secondary attack rate. So for the person-to-person transmission, the best measure is what we call the reproduction number. It's a measure of transmissibility, and it also gives us a very good picture of how transmission from person to person happens. What is the reproductive number? It's just the number or the average number of successful transmission per infectious person. Generally, we have 2 conditions. First, we have a totally susceptible population. The black humanoid here, it's susceptible. The red is infected, and the green is immune, meaning that protected from infection. So in this population here, everybody is susceptible. No one, I mean, we don't have anyone here who is immune. In this case, when an infection starts, we can talk about the basic reproduction number. So it's how many, what is the average of number of people who will become infected when an infectious person enter in a population where everybody is susceptible. This is called the basic reproduction number. It is generally noted like this, R with a zero subscript, and they usually call it R naught. For example, the SARS in 2003, we could measure their basic reproductive number because everybody was considered to be susceptible because it was the first outbreak. There are cases where some people in the population have immunity against the disease. So in that case, we don't talk about basic reproduction number, but we talk about effective reproduction number. And the effective reproduction number is just the basic reproduction number multiplied by the proportion of those who are susceptible. Mathematically, R naught, or the basic reproduction number, is the transmission rate times the duration of infectiousness. We can further break the transmission rates. The transmission rate is composed of two elements. We have the contact rate, which is the rate at which people get contact one another, and we have the transmission probability. What is the risk of a person A to transmit the infection to person B whenever there is a contact? And most of the interventions in public health, interventions to control infectious diseases, most of them will target either one or a set of these elements here. For example, when we do isolation of cases, generally referred to as quarantine, generally we are decreasing the rate of contact. When we decrease the rate of contact, we are decreasing the transmissibility of the infection. We can look at some other interventions that are implemented to control the probability of transmission. For example, the use of condom. When we use condom, we decrease the probability of transmission. In that way, we decrease the transmissibility of the disease. Antiretroviral therapy for HIV-infected people. When you take it, the number of virus in the blood will decrease. So in that way, you decrease also the probability of transmission. Vaccination, any kinds of prophylaxis we use, we are playing on this factor here, or even treatment. The duration of infectiousness. Some infectious diseases can be treated by antibiotics. When you treat, you decrease the duration of infectiousness, you stop the transmissibility. So most of the interventions will be playing on one or many of these factors here in order to control the infectious disease. But what does it really mean practically? R naught of 1 means that one infectious person can give infection to only one new infected person. In that case, we have an endemic stage because only one person can transmit the infection to another one, only one to one. When R naught is more than 1, it means that one infectious person can transmit infections to more than one people. In this condition here, we can have an epidemic because more and more people will be infected and then become infectious. Then when R naught is less than 1, one infectious person transmits to less than 1 people. So we have a possibility here of seeing the epidemic dying off. How do we measure that? For example, here, let's assume that the primary case is this one here. It could transmit infection only to 1 person, so he has transmitted to 1. Here, the secondary cases could transmit to 2 people, so he has 2. This one here could not transmit to anyone, so 0. It could transmit to 1, so on and on. And then when we take the average of that, we can have the basic reproduction number. For example, here it's 1.5. 1.5 tells you that the infection will continue on and on and on because it's more than 1 in this scenario here. More illustration. We have an R naught of 1, meaning that 1 person can transmit infection only to 1 person. For example, this one here becomes infected, and it goes on and on. But we will have an endemic stage. The epidemic will not take off, but we will have a stage where the epidemic is there, it's not taking off, it's not dying off. In this scenario here, the reproductive number is 2, the basic reproductive number is 2, meaning that 1 person can transmit infection to 2 people. So in this case here, it goes like this, it goes, and it goes. So as you can see, the more we go, the epidemic spreads very rapidly. So we have here a risk of epidemic. But let's look at this scenario here. In this scenario, we have some susceptible, but we also have some people in the community who have immunity, so they cannot develop the disease. So we have an R naught of 3. This means that 1 infected person can transmit infection to 3 people. So here, it could transmit to 3, but the 2 here are resistant because they have immunity. They cannot become sick. Only 1 here is susceptible. In that case, it's only that 1 who will become infected. And in the next transmission round, this one can transmit to 3 because the R naught is 3, but he had contact only with those who were immune, meaning that the epidemic stops here. So what does it tell us? It tells us that even if the R naught is more than 1, if some people in the population have immunity, the infection may or may not take off, depending on how many people in this community have immunity. And you can see that some people here, they are susceptible. They can become sick, but they didn't become sick even if they were not immune. They were protected by the people who are immune. So people who have immunity in a population actually protect people who don't have immunity. That is why it's not important when it comes to vaccination. It's not important to give vaccine to everybody 100%. You just need to give vaccine to a fraction of them, and the other one would be protected indirectly. And this kind of indirect protection is what we call herd immunity. It's the protection that people who are susceptible in the community get from people who are immune. So it is called herd immunity. This is example here. Let's look at it in a big slide. This showing the expected number of cases for polio vaccination in the US between 1958 1961. So it shows the expected number if the vaccines protect only those who receive the vaccine. We will have this number of reported cases. But in reality, the number of reported cases was much lower here. So this means that some of the people in the community who didn't receive the vaccines were nevertheless protected by herd immunity. So herd immunity is a very, very important concept. And this is a very important concept that is used in immunization and vaccination programs. You want to know how many people in the community do we have to vaccinate in order to protect everybody. So there is a lot of mathematical formulas here, but I will try to make it very, very simple for you. So remember I said that the effective reproduction number is just the basic reproduction number multiplied by the proportion of those who are susceptible. And this proportion here can be written in another way. The proportion of susceptible is, because it's a proportion, the maximum is 1. It is 1 minus those who are immune in the community. So we have this formula here. So for an infection to take off, the reproductive number here, the effective reproductive number, should be more than 1. But if we want the infection, we want to control the infection, we should make sure that the reproductive number here is less than 1. So this here, which is our effective reproduction number, should be less than 1 if we need to control the epidemic. So from this formula here, we can deduct what we call the herd immunity threshold, which is the smallest fraction of people we need to immunize or we need to give vaccine to in order to have a good effect for the vaccination. So the herd immunity threshold is just R naught minus 1 divided by R naught. Let's see some examples here to make it more realistic. For example, in this scenario here, R naught is 4. 4 means that you can transmit infection to 4 people. If no one is immunized, so F is 0, no one has the infection, this means that the effective reproduction number equals the basic reproduction number in that scenario. And 4 people would be infected in this case. But if 25% of the population here is immunized, what happened? What is our effective reproduction number becomes 3. So if we vaccinate 25%, even if R naught is 4, the person here can transmit the infection only to 3 people here. Let's increase the vaccination to 50%. When we increase to 50%, it can contaminate only 2. And when we increase to 75%, it can transmit infection to only 1 person. So this means that if we give more than 75% as a vaccination coverage, we will stop the transmission with an R naught of 4. Let's take a very small R naught. Here, it's 1.2. With 1.2, if no one is vaccinated, F is 0, it can contaminate 1.2 person. This is, that means that the infection can go on. But if we vaccinate 25% of people, our effective reproduction number becomes less than 1. And we can go on and on. But what does it tell us here? It tells us that if R naught is small, it takes only a small fraction of people to be vaccinated in order to be able to control the epidemic. So this is very important. Any vaccination or immunization programs that consider that, how many children should we vaccinate? How many adults should, or elderly should receive flu vaccine, for example? We need to know the R naught of the specific infectious disease in order to be able to estimate the number of people who should receive the vaccine. And as you can see, different diseases have different estimated R naught. For example, for diphtheria, it's 6 to 7, and it has also different estimated serial interval. You remember, we've seen it in the beginning of this lecture. Measles has a very high R naught, means that measles can transmit very effectively, because one person with measles can give to 12 up to 18 more other people, compared, for example, to influenza, which can give to 2 or 4 people. This also means that we need a higher rate of vaccination for measles compared to rate of vaccination for influenza. Measles is much higher because the R naught for measles is much higher compared to that of influenza. So there is obviously a relationship between R naught and how many people should we vaccinate. As R naught increases, the number of people we should vaccinate also increase. But at a certain point, maybe from 7 here, it's reached a plateau. So even any further increase in the R naught is not followed by a big increase in the vaccination rate or coverage. But the take-home message is that the vaccination coverage is based on the value of R naught. Bigger R naught means higher vaccination coverage. Lower R naught means lower vaccination coverage. Another message is that you don't need to vaccinate everybody, because those who receive vaccination, those who are immunized, can indirectly protect those who are not immunized. And this is what we call herd immunity. Let's make it a little bit complicated, okay? But also simpler at the same time. In this slide here, we're trying to see the relationship between R naught and the average age at infection. So let's assume that the infection that we are dealing with here gives immunity after infection, like measles. When you're infected with measles and you develop immunity that protects you against further infections in the future. And let's also assume that we have a rectangular age distribution, meaning that life expectancy is very constant, is a constant in a population. So we have these two assumptions here. So we can estimate the proportion of susceptible. So in a population of susceptible and where some people are susceptible and some are immune, the proportion of susceptible is given by this relationship 1 over R naught. And we can also estimate in a very different way the proportion of susceptible looking at the age at infection. So this is the overall life expectancy, and people get infected at some point, and we have the average age at infection. This is represented by the capital A. Their proportion of susceptible is simply dedicated by doing A over life expectancy. There are some mathematical background below, on the background to arrive to this formula. But I think understanding this is enough for you to understand the relationship between R naught and the average age at infection. So because the susceptible can be estimated by 1 minus R naught, and it can also be estimated by the average age at infection over life expectancy, we can come to this relationship between R naught, average age at infection, and life expectancy. This showing us something very interesting. Remember, we say that life expectancy is a constant. So a constant doesn't change over time. It remains the same. So if R naught is small, if we want to keep this the same, the average age at infection should become large so that life expectancy is kept constant. If R naught is large, in order to keep life expectancy the same, the average age at infection will become low. So technically, this means that infection with very high reproductive number, people get infected at lower age. And if the infection has a very small reproductive number, people would get infected at much later age. We have some, I have a graph for you here showing 3 infectious diseases that can induce immunity. We have measles, varicella, and mumps. So what do you see here? You see that people with measles get infected much earlier, at when they are 5.6 years old. With varicella, it's 6.7. With mumps, they get infected when they are 11 or around 12. So why? Because measles has a much higher R naught compared to varicella, and varicella has a much higher R naught compared to mumps. So if R naught is very large, you get infected when you are very young. When R naught is very small, you get infected later in age. So this is the relationship between R naught and the age at infection. Another important relationship to look at is the relationship between R naught and the average age at infection, but based on the settings, urban and rural. For example, you see, even for the same disease, we have in green here, measles. Even for the same disease, the age at infection is different when we are in an urban area compared to when we are in rural area. Why? It's because we can come back to this formula here. Remember, we said that R0 is the rate at which people contact each other, the probability of transmission, the duration. So in urban area, we have high population density. This means that people have high contact rates. In rural area, we have low population density. People contact, and the contact rate is much lower. So in urban area, R0 is much higher than in rural area because of the difference in terms of the contact rates, depending on urban and rural here. So for the same disease, the settings and other elements here can influence the average age at infection. So again, we are in this formula here. R0, our effective reproduction number, equals R0 multiplied by the proportion of susceptible. And this is a very important element to keep in mind, is that the proportion of susceptible and R0 influence the dynamic of an epidemic. If the proportion of susceptible equals 1 over R0, if we put 1 over R0 here, reproductive number will equal 1. And when it's 1, we have an endemic stage. If the proportion of susceptible becomes more than R over R0, we have an epidemic. If the proportion of susceptible is lower than 1 over R0, the epidemic will die out. So how many people are susceptible in a population is a very key characteristic that will tell you if an infection or an infectious disease will take off or not. So if everybody here is susceptible, if someone with infectious disease like influenza come, we all have the risk to get the infection. But if many people are not susceptible, meaning that they are immune, the infection will not take off. So the proportion of susceptible and R0 are key parameters for any epidemic. Whenever you hear there is an epidemic, you should always think in terms of the proportion of susceptible and R0 to have an idea about what's going on. So this is here showing you just what's happened. As the epidemic goes on, the attack rate increases. The proportion of susceptible goes down because some people become immune, and R0 also is going down. And at some point, when R0 becomes 1 means that we have reached a plateau, a stable point. So it's the peak here. And we drop at less than 1. When we drop at less than 1, the infection starts going down because R0 is less than 1. And it's the number of susceptible also goes down, meaning that people are becoming immune here. So at less than 1, the infection stops, the epidemic stops. So you can see the relationship between the number of new infections, the attack rate, which keeps on increasing. Over time, the number of susceptible decrease because R0 also decreases here. And this is the reason why some epidemics, we have these peaks here. Whenever we have an epidemic, when you look at a graph, there is a climbing point where more and more people are getting infected. Here, the proportion of susceptible is more than 1 over R0. That's why the number is increasing. And it reaches the point where the proportion of susceptible becomes equal to 1 over R0. The infection cannot increase anymore here. And then when it becomes less than 1 over R0, the infection goes down. we don't have many susceptible and infection drops. The next wave will come only when the proportion of susceptible becomes greater. So that's why we have this warning over time of epidemics. So the factors to consider here, it's susceptible, the number of susceptible or proportion, and the R naughts. It was a little bit complicated, but it's gonna get much complicated here. So we're going to see some consideration about mathematical modeling of infectious diseases. Why model? I'm sure everybody has heard about the term model, and you have your own definition in your head about what is a model. But before we reach to that, I would like you to think about some of these questions here. You don't have to give an answer, just think by yourself for a few seconds. The first one is, in order to mitigate mortality from seasonal influenza, should we vaccinate children because children are most likely to get infected? Or should we prioritize and give the vaccine to the elderly because the elderly are most likely to die from the infection? Who do you think should be the priority for vaccination for seasonal influenza? Just think in your head for a few seconds. The next question, should we close schools in case of influenza pandemic, or should we implement border controls in the airports or any other entry ports? What is the best to do? And in each of the options, when should we start? Do we have an idea? Just think about it. Next, why can we eradicate smallpox, but we are not able to control obesity? How much more do we need to do in order to eradicate polio? So as you can see, those are very complex questions, very difficult to answer intuitively. Like, we don't really know on which grounds to base our opinion sometimes in order to answer those kind of questions. Or we don't have empirical evidence to support our statement, maybe. And let's first see the definition of mathematical modeler, and then we will come back to that later. A model is just a simplified representation of a complex phenomenon. So we try to make something that is complex, we try to illustrate that in a very simple way. So it's in a very organized way. So this is a model. We have many kinds of models. Animal models, I don't know if some of you have done some lab experimentations with mice and trying to test the effect of drugs, for example, or to block some genes and to see what will happen to the mouse. So we also have mechanical models. But today, we mostly talking about mathematical models. What is a mathematical model? It's a representation of a system or process in a mathematical figure or form in which we use equations to make some simulation of the behavior of the system or the process under study. This is a definition but last. It's still very complicated to understand at this level what is really a mathematical modeling. When you will get it when we come to some examples. And in the mathematical modeling, we use population parameters and in forms of symbols, and there is a relationship between different components in the system in using algebraic formulas of mathematics. Why we use models? Because remember, I asked you many questions here about what should we do to eradicate polio. Why are we not able to stop obesity, but we can eradicate smallpox? So all those questions, we can make some sort of simulations using mathematical models to try to see what may happen if I do this intervention, what may happen, what kind of effects can I have. So with the mathematical model, we can get an insight or an understanding on what's the mechanism that influence the disease spread or the disease control within a population. We can also estimate some epidemiological parameters. It's help us to predict some future trends. A very simple not simple, but I would say some very common mathematical model that you are very used to is the weather forecast. Some people are used to check the weather forecast every morning to see how the temperature is going to be like. Is it going to rain? And what is the chance of the rain? Is it going to be cloudy? So we always check the weather forecast in the morning to have an idea about the temperature of the day. So they do modeling, they do mathematical modeling, and they make prediction about the future trends. So in the same way, we can do with infectious diseases, and we can simulate interventions to see if I use the intervention A, what kind of results can I have? And if I use intervention B, what results can I have? And we can compare different interventions. For example, if I close schools, in case of pandemic influenza, what would be the effect? And if I close the airports, and what would be the results? We can compare interventions of different interventions using mathematical models. They are not perfect, but they give us an idea about what's the best scenario or what's the worst scenario to take. So this is a very, very important element, predicting the future trends, checking scenarios, and evaluating different interventions. So we're going to go very slowly, step by step, into different building blocks of mathematical modeling. There are steps to come up with a model. As in any research activity, we start with a question, a research question. What are you looking for? What is your research question? This is really important because you need to have a very clear research question. What is your population? What kind of intervention do you want to implement? What effects are you looking for? So you always start with a research question. And just the same, every kind of research, you go to the literature review. You want to know what is known about this problem, what is written about it, what are the missing information, for example, what are the gaps. So you do a very detailed literature review about your research question. The next step you have there, what we call modeling design. It's a sort of study design for mathematical modeling. And then you start setting up the model, like putting everything together. Model quantification, we're gonna see it later. And model validation, you want to make sure that your model really works and if it's really a good one. If you develop a new model for weather forecast, you want to compare it with other weather forecast companies and see if it's working well. So these comparisons with other models or other already working operational models is what we call model validation here. Once the model is validated, then you can start using your model to answer your research questions or to make some prediction. But if it's not validated, you can go back again. So it's a tremendous efforts. You can go back again. You can go back to each of the steps and see what was wrong until you come up with a model that is well validated and that can be used to estimate or to make prediction. So let's start with our research question here. The research question is, what is likely to occur if a new strain of influenza enter into a population of 100,000 susceptible? How will the average number of people who are susceptible, infectious, and immune will change during the following weeks? So we have a population of susceptible, meaning that none of them is immune. And we have one infectious person. Is infectious because he can contaminate or transmit infection on to other people. So we would like to see what would be the change in the population who are susceptible and among those who become infectious and immune. So let's assume that this is a closed population, like there are no entry, so no migration in, and no birth, so it's closed, and there are no migration outside, so, and no death, no one is dying. So this is just for understanding what may happen. So we have a closed population here. And let's also assume that if you become infectious, you will later become immune. And when you become immune, you're protected for all your life. So we have two assumptions here. So we have our first step here, it's our research question. So this is just for you to remember again. Susceptible is someone who's not infected, but who can potentially be infected if he's exposed, if he's in contact with someone who is infectious. Infected is someone who is infectious, who has the infectious agent, but he cannot transmit the infection to other people. Infectious is that you are infected, but you are also able to transmit the infection. Immune, it's simply that you're protected. But in our case here, we don't have infected. We just assume that once you become infected, you are also infectious. You can transmit. So we're trying to make it very simple here. As I say, we need to look at the literature. The source of the literature can be the research articles, gray literature, previous models of the same issues or similar issues. And you can organize it into different categories. For example, how long is the latent period of other forms of influenza, for example? How long is the infectious period? In our case, it's a new strain, but we want to see also other forms of influenza. What is the R0 of other forms of influenza? Does the infection affect all the age groups, or does it affect mostly children or adults? So you kind of really, as an investigator, try to see in details the common characteristics of the infections that is in the literature. So for example, in case of previous influenza cases, the latent period is about 1 to 2 days, and the infectious period is about 5 days, and R0 is about 1.5 to 3, meaning that the infectious can go on and on if no one is protected. So the third step is the model design. In the model design, there are some points to always keep in mind. The first is the natural history of the disease. The natural history is when a person is sick, and we try to see every steps how the disease evolves with no intervention, no medication, nothing. So we see what are the different stages of the disease. That's what we call the natural history of the disease. So every infectious disease have a particularly different natural history. For example, the incubation period is generally different depending on which infectious disease we're talking about here. So you need to know, to have an idea about the natural history of the infectious diseases that you are dealing with. And also the prediction period of the model. For example, if it's you want to make prediction over long term, for example, 2 or 5 years or 10 years, you will need to consider factors like birth, death rates, population migration, because it is likely to affect the characteristics of your population. So it's really important to consider the demographic parameters here. But for our research question, we really make it simple. There is no birth, there is no death, there is no population migration. And also your research question is a very important element to consider about the design. The same way when you're doing any kind of research in epidemiology or in public health, the type of research question that you have kind of tell you what kind of design you have to follow, cohort study or cross-sectional or qualitative research. So the same way here, your research question will tell you what kind of model structure you need to consider. There are many types of model structures. The simple one, for example, is SI, susceptible, infectious. So when you are susceptible, directly you become infectious. This is HIV. Generally, when you're susceptible, once you get infected, you become infectious. And you remain infectious until you die, or if we consider the natural history. But we have another one, SIS, susceptible, infectious, but the infectious can come back here to become susceptible. Those are cases of short curable sexual transmitted infections like chlamydia or gonococcal infection. If you have it, you become infectious. Once there is a treatment, you are cured, you become susceptible again. So it's like a circular movement here. We have the SIR, susceptible, infectious, removed. Removed here means you are maybe immune or maybe the person is dead. So that's in the mathematical notation, we say removed here because you are removed out of the system, out of their infectious dynamics. So we have, the next one is the SIRS, this one here. It's just the same one here, but you come back to the susceptible. If you are immune here, you remain here in case of SIR. But in case of SIRS, the removed can come back here. For some infections, you can lose your immunity over time. For example, some cases of mumps, people can lose their immunity and become again susceptible here. And then we have the SEIR and the SEIRS, same. The only difference here, just we have this stage here. Remember, I mentioned in the beginning that you are infected, but you cannot transmit the infection to other people. So this stage here, we don't have it in the SIR. But for our model structure, we will make it very simple. We are working with SIR, meaning that we have susceptible. Once you leave the susceptible box, you become infectious. So meaning that you can transmit the infection to other people. And the next step, you become, you are removed, you are immune forever. So our model for today is the SIR model. So this is our population. We're going to try to make some simulation here. Firstly, I just want you to see how people may move from different blocks here. We have 3 blocks, the blocks of susceptible, infectious, and removed here. We have our assumptions. Remember, we say we have permanent immunity. So if you become immune, you stay here forever. Closed population, there is no entry, no birth, no death, and no migration. And we assume that once you're infected, you become infectious directly. ST is the proportion of susceptible or number of susceptible at time T. Time can be 1 day, 2 days, in terms of days, or in terms of weeks, or in terms of year. So you need to decide about the time step you're using. So you want to talk, maybe for our case here, we're talking in terms of weeks, or we can make it even simpler in terms of days. But ST is the proportion of susceptible at time T. IT is the number or proportion of infectious at time T, and the same for removed, the proportion who are immune at time T. So what may happen? We started with one case here. He infected 2, and because they are infected, they move to the next box here, and 1 becomes immune. When you become immune, you have to move to the next box here. And we have 2 newly infected here. They were susceptible, they are now infected, so they have to move in the infectious box here. And we have 1 who got infected. He becomes immune, so he moves there. So if the time step is every day we're gonna see some migration of people from one block to another block. And this is what we try to simulate now. How can we estimate the number of people who will remain here over time? So if I come after 10 days, how many people will be here? And after 10 days, how many people will be here or here? So we can estimate that by using mathematical parameters and model to estimate how people change in each of the categories here. And all the migration is, we're gonna see that in coming slides, how to estimate for each of the block here. But before we get to that, we need to think about the methods. There are generally two big methods. We have what we call deterministic models. To make it very, very simple, deterministic model give you only one prediction. You have only one estimation here. It gives you on average what's happened. It will tell you, for example, on average, 2 susceptible becomes infectious every day. Or at average, 3 infectious become immune. So we have only one line of prediction. But for stochastic models, they introduce the notion of time and chance in the number of people moving from category to category. It gives you many scenarios that will tell you on average, for example, 10 to 13 people moves. So because we have a component of a stochastic component using chance here. But for our model in this today's lecture, we're going to use a deterministic model, which is much simpler to understand. So once we decide about the model structure and the model methods, we need to set up their model. And this is very important parts in mathematical modeling of infectious disease. Set up the model, because you use difference equations here or to try to predict the changes. So we will use what we call difference equations. The difference equation is generally expressed in terms of time steps on daily, weekly, or yearly. So with difference equations, we can be able to express the number of individuals at given time plus 1, for example, tomorrow, in terms of the number of an earlier time. Simply, it means that I can predict what will happen tomorrow based on what I know today. So tomorrow can be predicted by the information that we have today. And then when you arrive tomorrow, you can predict the information that you have on that day to predict the following day. So we're using the time t, the information at time t, to predict the information of time plus 1 by using difference equations. It's very simple to understand. For example, we have the susceptible here. Let's try to predict how the number of susceptible changes over time. So we have our susceptible group, infectious group, removed group. So when we want to predict how the number of susceptible changes, we just want to know how many people get out of this box every day. Time plus 1, time plus 2, how many people go outside and how many people remain here. And in that way we can predict the risk of infection, the risk of someone who is here to become infectious is generally noted lambda t. It is the transmission probability times the number of people who are infectious. Simply, in this classroom here, if no one has influenza, the risk of infection here is 0 because no one in this classroom has influenza. So the risk of infection depends on how many people have the infection in a population. No people means the risk is 0. But it doesn't only depend on how many people have the infection, but it also depends on the transmission rate. What is the probability that the transmission will happen even if some people have infections here? So let's see it now. Here we have 2 people who became infectious. They have to leave the box. So the 2 here, it's the number of those who become infectious at time plus 1. So 2 has gone. And the formula to calculate how many people becomes is this one here, lambda t. Lambda t, remember, is the risk of infection multiplied by the proportion of susceptible. So if we want to predict the changes here, the number of susceptible at time plus 1, it's the number of susceptible that we have today minus the number of those who went out. It's this one here. So by just subtracting this group here, we predict the number of those who stay here. And it can go on and on, the same scenario. We can do it on and on. For example, 2 more people become infected. So these one are the newly arrival. And we can predict for many other cases. So this equation here is very important because it is estimating the number of people that remain here by each time step, like time plus 1, at time plus 2, you can continue time plus 3. So now we are here, infectious. We can also use equation to predict the number of people here who are staying here every day. In a very intuitive way, you know that some people will come here, so there is a plus, and some people will leave this box, so there is a minus. So we have a plus and a minus. So we have the new people here. It's the number of newly infected people. And we have a minus. This is the one who become immune, leaving the box. It's given by this formula here. The recovery rates multiplied by the infectious here. So to predict the number of infectious, we just need to know the number of people who are there at time t plus the newly arrival, those who were here, who came in this box, minus those who recovered here. So these equations here help us to predict the number of infectious people here. The next, we want to predict the number of people who are removed, so who become immune here. This is also much easier. It is based on the risk of, the recovery rate, R. So how many people leave the infectious box to join their removed box? This one becomes infected, comes there. So the risk of recovery is just noted by R, multiplied by the number of infectious tells you the number of people who become removed. And we have our equations of the number of people who becomes removed at time plus 1. So with the three equations here, we can predict the movement of individuals from one box to another box, and over time, at time plus 1, time plus 2, time plus 3. So we can just use these equations here. The fifth steps after making the equations, you need to specify the model inputs. They call it model quantification. Model quantification means you need to tell the values for each of the parameters in your model. For example, lambda t is the risk of a susceptible to become infected. You remember, they also call it the force of infection. We need to know the value of lambda t. R, which is the recovery rate, the risk of infectious to recoverers becomes immune. Between t and t plus 1, we also need to know the value. So we need to quantify our parameters. So this process of quantifying the parameters is called model quantification. And most of the time, you will find the information in the literature review, during the literature review stage, in the beginning. So you want to know what is the R naught and what is the risk of transmission as well as the risk of recovery. For example, remember the force of infection is the transmission probability times the number of those who are infectious in that population. So this is the formula. As I mentioned, if no one is infectious, the risk of transmission or the force of transmission is 0. So the number of infectious people in a population or a given population gives you an idea about the risk of transmission in that population. Regarding the recovery rate, how long it takes someone who was infectious to become immune, you can estimate it by just doing 1 over the duration of infectiousness. So if you know the duration of infectiousness, you know their risk of transmission rate. So we have a lot of challenges. We have lack of reliability data. Sometimes it's really hard to find reliable data. Sometimes you need to collect new data when you do the modeling. And sometimes there are some very sophisticated techniques for estimating some mathematical models. Then we have the model validation. As I said, the model validation is the stage where you need to compare the results of your model with the other models that are looking at the same thing. And then you can use your model for prediction to see how many people changes in each of the box, infectious, susceptible, and immune. And there are softwares to do that. What I use is the Berkeley Madonna, but you can use a very simple Microsoft Excel to do a very simple mathematical modeling. For example, for this exercise, just with an Excel, you can have this kind of estimation, and you can estimate the number of susceptible inputs and infectious disease. So this is just a simulation of how the transmission can happen over time, the number of infectious, the number of immune, and the number of susceptible. So this was just to give you a very, very short introduction about mathematical modeling. And for those who are interested and for more questions, you can come in our department for discussion. And sorry for taking too much of your time. Thank you very much.